Dr. Ben Szirth. I'm at the Rutgers Medical School and in New Jersey, in the US. I'd like to speak to you today about the use of retinal imaging in the capturing of diseases such as diabetic retinopathy, glaucoma, and age-related macular degeneration. Those we call VTD, vision-threatening diseases, and we will go through some of these cases. As you all know, the diabetes is on the increase worldwide, and Latin America, or South America more precisely, is projected by 2030 to have an increase of roughly 60% of diabetes. Now, why is that? Well, it's lifestyle, but it's also because people are more aware of the need to be checked. So by having instruments that check the eyes of individuals, we're going to have an increase. So it's not just the increase in diabetes, it's the awareness of diabetes. So it's important. In Argentina, we're looking at a increase up to 9.6%, but is that increase due to the lifestyle, or is it because we're capturing diabetes more because we're looking more? Roughly 1.8 million people have diabetes, type 2, and blood sugar level has increased in the amount of awareness. Checking yourself for your blood glucose level has now risen to 76%. It's estimated that half the people that have diabetes do not know they have diabetes, or that they have glaucoma, or that they have age-related macular degeneration. So the screening programs to detect the diseases is very important, so we can capture the disease as we see it. And again, the increase in diabetes in Argentina is, I believe, in two folds. One, as reported, because people are aware or there are screening programs, and number two, because of lifestyle change. So we're going to address that. Blindness in the United States, USA, we have 6 million people that are blind in the USA, in the white population, so 2.5% of the population. And then we have the African American, the blacks, Hispanic, Asians. And again, it's important to know that half the people that have diabetes do not know they have retinopathy. So it's important to check and do programs. We do checks in Haiti, in Honduras, in Europe. We go everywhere and check. It's important to control the blood glucose level, but for me, someone with diabetes, it's really vital to be able to look at the blood pressure. So if you have diabetes, type 2, and you're overweight, your BMI is over 30, then it's also important to check what the blood pressure is. And why is that? Because with high blood pressure, you can have vessels that will break and create flame hemorrhages that could cause blindness. So it's important to control your glucose, but control the blood pressure. So every screening we do, we will do diabetic screening, we will do blood pressure, and we'll do glucose. So again, checking the increase, and we'll see this young patient. This is a type 1 diabetic. He's 21 years old, 16 years with type 1 diabetes, and his blood pressure at 21 years old was 145/95, and you'll see the results of his retina. And so what happens is blood vessels break, they leak. So we're going to talk about two cameras. One is we'll have to edit that. I don't know why I did that. Okay, we're going to talk about two cameras. One is the CR2AF, the other one is the CR2AF+. The difference between the two is the ability to do autofluorescence, and we'll talk about the value of autofluorescence, and not having autofluorescence. So Canon has been producing non-mydriatic retinal cameras for 40 years. It's the first one that has ever appeared on the market. Non-mydriatic means the pupil size is at 3.2 millimeters. The angle of view is 45 degrees with an LCD. It has optical filters as well as digital filters. It allows you to autofocus, auto-shoot, and the plus AF will give you autofluorescence. So vision-threatening disease are the various cases of, for example, diabetes and things like that. But when you look at these images of these 4 different patients, you wonder who has the best vision of these 4. We can eliminate this one, we can eliminate this one. This one has a good vision, this one doesn't. So until the vision is actually obstructed by hemorrhage or other events, the patient doesn't realize that they have something. And we call that vision-threatening disease. This is our team at Rutgers Medical School. There are medical students and physicians that partake in this program. I will show you here this one case. This is taken with the CR2AF. It has autofocus. And you wonder, is this patient okay? Would you keep this patient and follow them? Well, if you just capture the color image, you will notice that the cup-to-disc ratio might be a little bit large here, but is it of concern? If you have the autofluorescence added to the retinal camera, that's a second type of brand, this is the difference. So in this case, you can see the retina looks normal, but in reality, there's a lot of events that we're missing in the color. Here's a second patient. We're looking at the color photographs. This patient was complaining about having poor vision in her left eye. We did autofluorescence with a 2AF+, and this is the results that we have of this patient. The reason she had a decrease in vision is because the macula was involved in this area that had edema. So that was completely missed in the color photograph. We do screening, so in the screening, we don't have the ability to be in a clinical setting. We may be in a church or at workplace, and so we'll see everybody walking through. So we don't know what they have, and that's why it's nice to have autofluorescence. And we'll show some other cases. In this case, we're looking at CSR. We're looking at the color image. The image is good, but the software has a program that we can enhance this image. So this is the enhanced image with software. And then looking at autofluorescence, the question we have, is it a progressive disease or is it a stable disease? In this case, we see the autofluorescence is hypofluorescent, meaning that there is no fluorescence. And that way, if this had, for example, banding, which would be hyperfluorescent, we would be saying that this is a progressive disease. But because it's completely black, it's non-progressive. So the added value to the CR2AF+ is it will give us the ability to say, is the disease progressive or stable? And again, we're showing 2 cases with image suppression. It's a digital software. Once we capture the image, the software will enhance that image and allow us to see the patient with cataracts and such. Also, the software has separation values where we have the color image. Once I capture this one color image, I can separate with the software in 3 values: blue for glaucoma, green for diabetic retinopathy, and red for choroid. We also have the ability to show this image with OCT. So we see the red-free for diabetic retinopathy, blue for nerve fiber layers, then we have red for choroid, and we have autofluorescence in the area of the retinal pigment epithelium. If we look at this patient, the question we have, is this a choroidal melanoma? So we will do a separation digitally. We can see in the green, we cannot see this area at all, but what we can see in the red value is the nevus. So if it were a tumor, choroidal melanoma, it would show up in both, but because it's only in the choroid, we know, and we can see it's flat, we can guess that this is probably a nevus that we would follow. The example here also of opacity suppression color images where we can see much better the small hemorrhages. And of course here also in hands where we can have a better value of what the images are. So if I separate, here's a patient with type 2. They have retinal hemorrhages, so I can do a red-free and look at the areas of hemorrhaging, but I can also create a 3D image with the software that will allow me to see the elevation of the areas of the software. And this is called Emboss, and it's software driven. Another case where Emboss is useful, if you look at this patient taken with CR2AF autofocus, we're going to say, is this patient okay? And doing the Emboss, suddenly I can see that I have a problem here, and this problem, of course, is the Ohlensort plaque that I could have missed, but doing this, and what's important is you can see the depth of the vessel here. And suddenly, after the plaque, you can see that there's very limited flow. This area versus this area has free flow versus limited flow. So talking about diabetes, what's happening in our population? Population is aging. We are being a sedentary lifestyle. We watch TV, we play computers, we don't move. So the obesity rate is climbing in both adults and children. And we have something that's very important, is that there's a 25% prevalence in diabetic retinopathy for areas of retinal edema. So being able to follow is important. They have also diabetic retinopathy. 1 in 12 has vision-threatening diabetes. 24,000 people will become blind annually. And of course, half the people don't get eye care because they don't know that they have a problem. So if I look at this case was captured doing a screening. We can also see that there's neurofibrillary loss, not just diabetes, and there are compromised blood vessels. And this patient, for example, also did not know that they had diabetic retinopathy. If we look at this case, this is a type 2 patient, 50-year-old, and we're looking at the various types of hemorrhages. We have dot hemorrhages and we have flame hemorrhages as well. And often people don't realize that they have a problem because their macula is safe. Doing screening, we can pick up those cases and we can actually help the patient to continue. This is a type 1 patient, 19-year-old, who was clear except for one small dot hemorrhage, but then he decided not to continue his follow-ups for type 1 diabetes and also wasn't careful about his hypertension and suddenly developed hypertension at age 21. 2 years passed, and in 2 years, this is 4 images that were captured, put together with the software, allows us to see a wider field. This did not require dilation, so we did it non-mid, but we can see the various areas of hemorrhage and flame hemorrhage because they had high blood pressure. The blood pressure was 142/62. Their blood glucose was 320 and their A1C was above 14. So we had roughly 271 hemes. So if you look at this patient here, we then did autofluorescence. The value of autofluorescence in diabetic retinopathy is I can pick up small hemorrhages that I would miss. More importantly, the patients that are young, under 30 years of age, they also have retinal reflex. The retinal reflex in autofluorescence is taken out. So you can see what's happening underneath the reflex with autofluorescence. You get a much better view. OCT showed me that the macula was flat, so there was no edema at that point. We were able to do FEZ of the macula, and then we followed through the patient. We then were able to control his blood pressure little by little, but here I'm showing again the view of the retinal hemorrhage in color, the black and white taken from this image, and a secondary image captured with autofluorescence to show that we can get rid of all the reflexes. So if we followed through time, 2010 to 2015, we're able to see that in 2013, his blood sugar level, his blood pressure, everything went up. And that's where we developed the serious problems that we can see here. From here to here in just roughly 2 years. So after we followed this patient, in 57 days, just getting the blood pressure down, look at the difference between here, this is now gone, only by giving blood pressure medicine. 92 days, everything started to look good, but the patient started to take CoQ10 at 21 years old. I don't know why, but it's a blood thinner, and one of the things, blood thinner, and it produced this smokestack flame hemorrhage that created this problem. So once we were able to get rid of that, then we were able to control a little bit better the values to safeguard the macula in this case. So we can see the difference in 57 days in wide field, and then 92 days, and then this was 2 years later. We basically got rid of most everything, and the patient regained good control from here to here, simply by having the patient return to control. The second case is at 18 years with type 1 diabetes. It doesn't look so bad. But then with OCT, we're able to see the changes that are happening. And then he had an A1C of 14. We brought him down in 5 months to 8.2. But still, the macula was being involved, even though this case looks better than the previous one. But with OCT, we're able to see the changes in the FEZ and see that he was progressing towards more problems. July to October, we can see the small hemorrhage resolving because the patient was in better control, but still the areas of edema were going up. So that's for diabetes. In glaucoma, we're able to use the color imaging, look at the optic nerve cup-to-disc ratio, look at nerve fibrillary drop-off, and then we're able to follow through and do cup-to-disc ratios. What's important here is in glaucoma, this is the perimetric glaucoma, we can see the small changes in the macula, we can see optic nerve, and if you look carefully here, we have a drop-off of the nerve fiber layer. So we can use the software and actually demonstrate in red-free that this nerve fiber layer has dropped off completely. Here it's good. It confirms that looking at the retinal nerve fiber layer thickness, that we have a drop-off area here, and we're able to demonstrate that with emboss, how there's a dip where the nerve fiber layers were, they disappeared. All this, of course, is included in the software that you have. So you just take a color photograph, and you can produce these type of images. To produce an embossed image, we can go into Photoshop and set these angles, and it will create a three-dimensional value of a color image, capturing just one single image. And here you can, of course, see the red-free. Here you can see the evaluation of where the nerve fiber layer is, but just with one color photograph. Of course, in glaucoma, we can look at the optic nerve with autofluorescence, and we can look at color, and then we can see what the OCT will tell us, but we always start with retinal photography. In this case, plasmosis, we had this patient, we did color photography, then we did autofluorescence to see if the worm that was in the eye, if it was progressive or it was dead. We're able to remove the worm, and once we remove the worm, we know that it's not going to progress. So they lost central vision, but they can maintain peripheral vision. And then the worm lived here, came and ate here, and had an exit hole here. So we removed the worm from the eye, and we're able to save the peripheral vision of that patient. But you can see that it's non-progressive because it's black. There is no white area of hyperfluorescence. So that's the added value of having autofluorescence. In the OCT, we can see where the damaged area happened in the macula. Advantages also of retinal screening. In this case, we can see the Zika virus. Zika virus typically shows up with black speckles. I think Argentina, in the north part of the country, has also problems with Zika virus. So it's possible to screen and pick up these changes along with the speckle bone lesions. Will OCT replace retinal photography? I don't think so. Retinal photography will remain, but in add-on to color imaging, autofluorescence, and OCT will give a much better value for pickup in screening programs where it's not done in a hospital where you have no help from others. This is our team for imaging in telemedicine, and we have medical students, we have physicians that all work together to bring better help to our patients. Thank you very much for your attention.